Hey, everybody, welcome back to the Healthy, Wealthy, and Smart YouTube channel. I'm your host, Dr. Karen Litzy. So again, thank you for tuning in, and don't forget to hit the like button, the subscribe button, the notification button. I think you all get the idea. So on today's episode, I'm really excited to have Dr. Rebeca Segraves back on the podcast. She was in a podcast last year. It was a group podcast, and now I'm really excited that she is back solo for today's episode. So a little bit more about Dr. Rebeca Segraves. She's a physical therapist and board certified women's health clinical specialist who has served individuals and families within the hospital and at home during pregnancy and immediately postpartum. She has extensive experience with optimizing function during long-term hospitalizations for high-risk pregnancy and following perinatal loss and pregnancy termination. In the hospital and home health setting, she has worked with maternal care teams to maximize early recovery after delivery, including cesarean section, birth-related injuries, and following obstetrical critical care interventions. She is the founder of Enhanced Recovery After Delivery, an obstetrics clinical pathway that maximizes mental and physical function during pregnancy and immediately postpartum, with hospital and in-home occupational and physical therapy. Her vision is that every person will have access to obstetric rehab therapy during pregnancy and within the first 6 weeks after birth, perinatal loss, and pregnancy termination, regardless of their location or ability to pay. So in this episode, we talk about why it's so vitally important to have an occupational therapy and a physical therapy consult in the hospital before you go home after childbirth. We talk about the major mental health components and what exactly PTs and OTs should be assessing in a person after childbirth in the hospital. We'll also hear about discharge criteria for PT and OT, preventing readmissions. And if you are a physical therapist or occupational therapist and you work in a hospital setting and you are wondering, how can I implement this in my hospital? Rebeca lays it out for you. She tells you what to tell those hospital executives and exactly how to map out a program like this that you can start immediately in your hospital. So a huge thanks to Rebeca Segraves, and thanks to you for tuning in and watching today's podcast episode. Hey, Rebeca, welcome back to the podcast. I'm so excited to have you on solo this time. So welcome back.
Thank you. So excited to be here.
Yeah, and today we're going to talk about, I know, something that you're very passionate about, and I believe most healthcare practitioners should be passionate about, and that is physical therapy and occupational therapy care in the hospital after childbirth. So why is this such a passion project for you?
Honestly, it was what happened in 2020 that really changed my career. I started out working with people after cancer. And I'll be honest with you, within 2 years, I thought I was going to burn out. So I talk to students now and other early professionals to say, listen, if you thought physical therapy was, really on the front line of preventative care, it's you who has to make that change, right? And I found that within the first 2 years, I didn't want to be the one treating lymphedema after, years and years or even months where we could have done things to prevent it. So early on in my career, I started a program where everyone after a mastectomy and a hysterectomy that was related to cancer received PT within the first 3 weeks so that we weren't seeing them after radiation. And so within 2 years, I was doing that out of PT school. And so in 2020, I decided I wanted to take a break from treating in oncology. I saw this really cool ad for a women's health clinical specialist in the hospital, in a hospital in Texas. And I said, wow, I've never seen that before. Women's clinical specialists, pelvic health specialists, we're known to work in the outpatient clinic. What is this about? And that is what actually was my first encounter treating women after, individuals after birth, after cesarean section within 24 to 48 hours after other pelvic surgeries, and I realized, whoa, this is a whole different population. I want to learn more about this. So that's kind of what got me on this path.
And it only makes sense when you think about it, because most people, when they have some sort of major abdominal surgery, let's say we're talking about cesarean section first. So let's say you have a major abdominal surgery that's not childbirth related. You are probably seeing an occupational therapist or physical therapist before you can be discharged from the hospital, because you have to make sure you can get out of bed. You have to make sure you can dress. You have to make sure you can walk, let's say household distances before you can be discharged. But I don't know that that was happening for women after cesarean section. What is that correct?
That is correct. So
Uh-huh.
I started out in acute care, working here and there in acute care, especially as a student, right? One of our clinical rotations, at least at that time when I graduated, had to be in acute care. And so in acute care, we were seeing individuals after hernia repair. Now, for people who don't, understand really, well, what is all involved around that, that's not a major open abdominal surgery. Usually, they're not having to make a large incision through the skin, the fascia, the fat, the muscles to repair a hernia. That would really defeat the purpose. They're doing that laparoscopically through robots, right? Very small incisions. So the fact that in the hospital we were treating people after a hernia repair or after gallbladder surgery or after, here's a common one, appendix removal, appendectomy. And we were teaching them how to get in and out of bed, how to make sure to monitor their own vital signs in case they were getting short of breath, if they, were still recovering or weaning off of the anesthesia, and just making sure that they could do things like stand in a shower, that they didn't need a shower chair to sit down, because in the hospital, you have a shower seat. We wanted to make sure that they could actually do one of the most demanding activities, which is actually showering, upright. And so we were doing that for the general acute care population. And so when I encountered an individual after a cesarean section, we're going 9 layers deep, including the layers of the uterus into the abdomen. It's a huge major surgery. And we weren't even laying their bed down flat, taking away the rails and helping them in and out of bed, let alone being able to carry their baby while they were negotiating their home. That was a game changer for me. I was like, we have to change this.
Absolutely. And having that major abdominal surgery and pulling out a human being that you've been carrying for 9 months. So talk about different changes within the body. And now you have to navigate a whole different body than you've just had. And they have the baby and they give you the baby and it's okay. Bye.
Yeah.
Good luck.
And it's true. And we often, right, we often will say those who've had a baby, right, are going to, again, be fine. They have the endorphins, they're bonding. They really don't need OT and PT to interrupt that golden hour. And I've heard arguments from both sides, but what really sealed the deal for me was actually treating individuals after a cesarean section who had lost their baby as well.
Mm.
And I realized these are still individuals after birth. They're still in the postpartum recovery period. And so they don't have the endorphins. They're not bonding with their infants. And now all they can think about is the pain, right? You can say the mental, the emotional, the pain associated with their grief, as well as the surgical recovery, that if we're not giving them those tools, those basic tools that we just talked about for the general acute care post-abdominal surgery population, how much more, right, are those impairments down the road? How much more could we potentially prevent for that population in terms of postpartum anxiety and mood disorders?
Yeah. Yeah. And physical complications that can go along with it. So
Absolutely.
what should physical therapists and occupational therapists, you can separate those out. What should PTs and OTs be assessing in a person after childbirth in the hospital setting?
Right.
So
And
let's say it exists, right? in an ideal world, every single person after childbirth is having a physical therapy and occupational therapy consult. So let's say there's someone listening who works in a hospital and they say, I want to start this in my hospital. What do they need to do?
First, recognize the two fields are very different. Occupational physical therapists, we lump them in like they're one word, OTPT, right? And so I had to learn from an occupational therapist, actually a pediatric occupational therapist, that my skill set, right, to assess mobility, transfers in and out of bed, making sure vital signs were stable with negotiating stairs, were very different from someone who's focusing on their ability to bathe and dress themselves, their ability to care for their newborn, their ability to prep meals, or to even arrange for transportation. Say if they're still on narcotics, but their infant has to have their first pediatrician visit within the first week. So I realized early on, working with this population in the hospital, I needed my OT counterpart. I needed someone to really focus this individual's attention on their own self-care and their ability to not only care for their newborn, but many times those individuals had toddlers at home. And so I formed a team as early as I could with, again, it was a children's hospital, right, with a wing dedicated for maternal care. But I formed a team with the therapists who were working in that hospital at the time were pediatric therapists, and really started to focus on what did OTs do in this area of function, what would PT's role be, and really start to define what that team care looked like, from a rehabilitation standpoint. Mm-hmm. And so we were able to focus on vital signs in each of these different activity areas. And so vital signs were not being tested with activity. And that's really the takeaway message that I want people to understand, is that a person can be up and walking, right, within 24 to 48 hours after giving birth. But if we're not taking into account what their environment looks like, if they have a high rise, if they have a second story, they don't have elevator access, if they're a single mom and they maybe have other kids at home, who is going to help them even take the carrier up the stairs? Yeah. We were encountering a lot of individuals with that. So we really had to define our roles as OTs and PTs, and really start a team approach that covered all the areas.
And what are you, let's say specifically, let's say someone has to be discharged from the hospital. What is the criteria for hospital discharge from an occupational therapy standpoint and a physical therapy standpoint?
From an OT standpoint, they should be independent with being able to monitor their own vital signs during more prolonged activity that's involved in bathing and dressing and caring for their newborn. Are they able to walk and carry their newborn safely without the risk of falling or dropping their infant? I worked in a large hospital where we actually tracked how many infant drops there were, per hospital stay. So you can kind of imagine if we were able to track that, we definitely should have had an OT on the team to actually prepare people how to not only be mobile during functional activity, but be mobile specifically with newborn activity. Mm-hmm. And so a PT looking at discharge would be looking at mobility, the ability of that person to protect if they had a cesarean section, to protect their incision getting in and out of bed. If they had a tailbone injury or a symphysis pubis injury, that is a full stop with me. I definitely want to see that person using an assistive device and not table or furniture walking to get around their room, right? Mm-hmm. Because they can't carry their baby at home. And I'm concerned also about them negotiating stairs if that is a barrier to them entering their home. And so a full evaluation by both disciplines is recommended after any type of delivery, because even if they really do check all the boxes, that's a low complex evaluation. We have done our due diligence as rehab professionals to make sure that this person is safe to go home, their vital signs are stable, and they are capable of caring for themselves and their newborn without exceeding their weightlifting precautions, if there are, after C-section,
Right.
or exceeding their body's, physiology in terms of their blood pressure going too high and putting them at risk for preeclampsia.
And I'm going to play hospital administrator right now, okay? Because this kind of came into my head. So PT and OT, they evaluate not ready, not given the green light to go home yet. They cannot navigate their space with their newborn yet. They need another day or two in the hospital. The hospital says, this is our average stay after whether it's vaginal childbirth or caesarian childbirth. How does that conversation go?
Your conversation with that scenario is always going to turn it around and focus on how you're saving the hospital money by preventing a readmission. Conversation should always be in favor of what that administration cares most about. And right now is turnover. I mean, ever since the COVID pandemic, and a lot of people, I was kind of floored that they didn't realize that the average hospital stay after a vaginal delivery was between 2 to 3 days, maybe. After a cesarean section was between 3 to 4. That dropped back. Mainly, 𝐊𝐞𝐲 was concerned about the risk of infection or exposure to COVID. And so when they dropped that back to 1 or 2 days after a vaginal delivery and 2 to 3, we really started to focus then on getting people out as fast as possible. Within 3 months of that change in my hospital system, I saw 3 different women, all after their first cesarean section. They all came back with infections with their cesarean incisions separating, causing them to have wound vacs, and on average, a length of 9 days in the hospital. That was the turning point where I really started to focus on preventing readmissions. Because not only around that period were we seeing readmissions from cesarean incision dehiscence and infection, we were seeing readmissions from preeclampsia. So I was able to sell the team on doing vital signs with activity to see if these individuals were really ready to negotiate this environment, right? That we had them separate from their families. This was during COVID that we were able to actually establish automatic orders for everyone after C-section. But during COVID, they didn't have the support at home because people were staying apart. So if we were able to do that in that large hospital system, which at the time was delivering about 500 babies a month, I say to any large metropolitan hospital or rural hospital, focus on readmissions, focus on preventing what we're all trying to address, which is the maternal mortality and morbidity crisis in this country.
Yeah. And how many people are on the team? So you said you were in a hospital, let's say delivering 500 babies a month, right? There's going to be therapists listening to this in more rural hospitals where maybe there's only, I don't know, 6 beds, 4 beds. I don't know. I don't know what the difference, you would know better than I would. So what is sort of the PT OT ratio, PT OT to patient ratio? What is in an ideal world where money is no object?
In an ideal world, it would not be 2 therapists, which is exactly what was on my team in 2020 when we started this initiative. We had 2 therapists, and at the time, I was the only one seeing patients with COVID. Patients, individuals who had COVID during pregnancy or immediately postpartum. So we were slammed. We were not ready for automatic orders to see everyone after cesarean section. And, for your listeners, not everyone realizes this, but a cesarean section is the most commonly performed surgery in the United States. That's more than knee replacements. That's more than hip replacements, shoulder replacements. So if you have a dedicated ortho team, dedicated OT PT team that's seeing however many knee replacements or hip replacements, a day, think about whatever that ratio is in your hospital currently. You might have to really then focus on, well, how many cesarean sections are being performed? How many of, say, these high degree lacerations are being experienced, like third and fourth degree peroneal tears? How many tailbone injuries? You really have to break it down and start prioritizing this population. Because in an ideal world, you would have a whole dedicated team to just the maternity population, like you would the ortho population, where you would the renal floor, where you would the cardiac floor. It is its own entity that has been for too long neglected. So it really, the ratio, I was seeing between 13 and 16 patients a day, and any acute care therapist will say, what? Hold the phone. But we're talking about a high volume. Birth is high volume, okay? And so really the idea behind providing OT and PT for this population is to address where we are as a country. And among the most developed nations in the world, the United States has the highest maternal mortality rate that's climbing. So sooner or later, we're going to have to join the national efforts of providers, of consultants, of doulas, of midwives, of all these birth professionals. OTs and PTs are going to have to get on board. We're going to have to start at the graduate school level of making this population as routine as your orthopedic, as your cardiopulmonary, as your neurologic population.
Yeah, I look back to when I worked in a hospital and there was nothing for people after childbirth, zero, nothing. And I even think about my own sister after she gave birth. She gave birth very fine, no problems, no major complications. She goes back, she goes out of the birthing room to a room in the hospital, baby's in the nursery. She has to go to the bathroom. The nurse comes in, she gets up and she hits the floor, passes out cold in the bathroom. Right. And I think no one, not myself included, mind you, no one was monitoring vital signs of her at all. No, nothing. And she, then all these nurses rush in and they take her out and she was not well, and it was, that's traumatic too. That's traumatic for a new mom. Because then you're like, oh my gosh, from a psychological standpoint, am I ready to take care of this baby? I can't even go to the bathroom without passing out. You know what I mean? And so I still remember that. And as you're speaking, I'm like, man, she would have really benefited from an occupational therapist and a physical therapist coming in and seeing her after she gave birth.
I think so. I have to, and I say I a lot, and I realize that we as a team depended on our nurses because we were really focusing on the elephant in the room with cesarean section. But it was our nurses who started to pay more attention when they realized what our overall goal was. And our overall goal was to reduce the amount that they had to do. A nurse in the OB has to monitor both the infant and the mom. They simply do not have time to take active vital signs, to go through a person's home environment like a case manager would. It's just not done on this floor. It's not done with this population. We have relatively, healthy people, and birth is not a medical, we've made it into a medical procedure, but it's the most natural thing that known to humankind, right?
Right. It's not an emergency.
The species is not an emergency.
Usually.
Right? Unless it is.
Right. Yeah. I don't want to say usually not an emergency.
Right. So in a normal situation, a nurse has enough already on their
Mm-hmm.
plate. And so for those individuals who have lost maybe more blood than normal,
Mm-hmm.
or, if they were on any medication that was really high, like Pitocin, really causing a lot of uterine contractions, and it was just kind of depleting their energy. If they
Mm-hmm.
had to have an emergency section or whatever it is, a nurse now has that much more to monitor. But that still leaves them in the same position of not being able to assess this person's home environment, their social support system, whether or not they have toddlers at home, whether or not they have other factors that are kind of impacting their recovery, and to ask them to take vital signs before and after or during activity, to go up and down the stairs, to make sure this person can stand in a hot shower,
Mm-hmm.
and prevent them from falling over. That's a lot to ask on our OB nurses. But
Yeah.
guess what? That leaves a whole field for us as therapists to really, really gravitate towards in order to improve that person's ability to recover from a major, major, major event.
Yeah. And what I'm hearing from you is exactly what physical therapists and occupational therapists can pitch to their hospital administrators to institute or um, to start up these programs within their hospital system. Is listen, if you bring your occupational therapist and physical therapist in, we will become a great team member to your nurses. We'll be able to take some things off the nurse's plate. We'll be able to, assess. So you've got a team approach. You've got taking pressure off the nurses. You've got hopefully lack of readmissions after discharge, right? So these are all positives that people can take to their hospital administrators, whether it's a large hospital system or a small rural hospital in, the middle of America. I
You
think
bet.
these are great, great talking points.
And you bet. And I mean, I'm leaving out probably the most important one. At least as of this year, as of 2022, right? We have started to see statistics that the leading cause of death postpartum is now suicide. Suicide. And so this is a huge mental health component, because not only can we do all of those things you just mentioned, we could actually probably turn someone's life around in a way of they have a support team that's focused on their function. If you're an athlete, right? I'm an athlete. I love mountain biking, love skiing now. I love, high intense energy sports. I just have a baby. I still identify as an athlete. I want to get back to my sport. And I've
Mm-hmm.
encountered moms who climb as well. They either indoor or outdoor rock climb. And that's so inherent to their identity that I've been asked within 24 hours of seeing a mom, who had a very high degree tear. It was borderline grade 4, really. It was like
Yeah.
that last grade 3C. And all she could think about is this going to affect me getting back into the gym? And she even apologized for it. She said, I know this sounds weird. I should be thinking about my baby, but this means so much to me, right? Because she was hoping for that 6 week check, off for her to return to activity.
Right.
As moms are told, unfortunately, not true for the most part. Recovery is much longer than that. But that was her focus, and that's what I directed my treatment towards, right? I directed it in a way that got her thinking about the future and getting her back into that role eventually, even though we had a lot to cover between now and then. And to me, that was a turning point for me as well, because I started thinking, had I not been there, and had I been one of those providers that are just like, don't overdo it and give you nothing more,
Mm-hmm.
right? That person is going to sit with that. They're going to sit with their pain. They're going to sit with the uncertainty, kind of the lack of specific information that they could be doing that takes control back into their hands. And that's going to wear on their mental health. So my pitch would include all of the above in addition to enhancing someone's mental health, their self-efficacy, their quality of life, and probably reducing for a lot of our population, the risk for them to hurt themselves, either unintentionally or intentionally, just because of the turmoil that they're still in. Some of our moms are really suffering with PTSD from having that unexpected birth that didn't go as planned.
Right, right. Yeah. And it's also an opportunity for the physical therapist or occupational therapist in the hospital setting to say, especially a woman like you just described, hey, you know something? Here are some options for an outpatient care after you're discharged. So here are your options. I'm going to put this in your chart. We're going to talk to the doctor about this to make sure you're taken care of afterwards. Because most women have no idea that's an option.
It's so true. My pelvic health therapists are going to love me for sending, about 60 more percent of your caseload to you, but it's true. It was a direct referral for our outpatient therapist. And it
Yeah.
was an opportunity for me to even connect with our orthotherapist. I said, guys, listen, this is not necessarily a pelvic health issue until it is, until it is.
Mm-hmm.
And so I found that someone having issues just with muscle and tissue healing, right? Muscle recovery, they could see an orthopedic specialist as well,
Sure.
a general physical therapist in the outpatient or home setting. We offer that for our people after knee replacement. They have the choice now if they can have their therapy in the home and be charged as outpatient.
Yep.
And
Absolutely.
so the more that we normalize this is it's a matter of time at this point for me, is that I teach people to pitch now to hospitals, to administrators, because it's just a matter of time until we're all saying the same thing and really offering an expansion of services for this population like we do anyone else. But it's a strong pitch for us to include our outpatient ortho folks who really can see the value of treating early tissue healing and repair, right? Because that's what it really is
Yeah.
before it becomes unaddressed and turns into a pelvic health issue. So I don't want my pelvic health therapist to think, oh my gosh, I'm already booked 3 months out. I can't get this person in. Well, that's when we start to really start forming teams. And if we can do it in acute care, we can do it for our outpatient ortho folks to get them prepared to see the postpartum population.
Yeah, I couldn't agree more. And I think it's such a great opportunity to be a part of your physical therapy community or occupational therapy community in your town or in your city, right? Because oftentimes in physical therapy, we tend to be siloed, right? You've got your inpatient PTs, you've got your skilled nursing, you've got your home health, you've got your ortho, you've got your ultra sports, right? There, you don't see this huge crossover. And I think it's one of the biggest problems with our profession and why we're not at the forefront of care across all of these platforms, because of this lack of communication and lack of cooperation. That's just my
Agree.
opinion.
Yeah, I mean, it brings us full circle to this conversation because, like I said, I started in oncology, and I have to give it to them. They're probably the most interconnected, area of health that we have. Are, oncology professionals who literally have. I mean, you can argue, well, it's a system of silos, but I don't think so. I've found that there was a lot of interdisciplinary care. And I was at the table in grand rounds. I was at the table where I was really valued for my input, working with OTs, working with registered dietitians, working with oncology case managers, and it was a coordinated team. And I found that I just brought that same approach to obstetrics when I started in 2020. I wasn't practicing heavily in obstetrics like I am now because I really, I didn't see a need for it. I was guilty. I was working in a silo and I was like, well, if they have an issue, I'll see them then. I wasn't really thinking preventatively. I didn't realize the scope of the issue as it is now. And if we use that same interdisciplinary approach, that community approach, and we didn't silo ourselves with this population, I think the care could be so much more than it is now.
Yeah. And wouldn't it be amazing in 10 years from now or 5 years from now, if there's more of this type of care after childbirth, wouldn't it be great to see that maternal mortality rates go down? And is there a connection between the two?
I'm I'm basing my career off of it. As a
Uh-huh.
physical therapist, I am making a claim, and I want someone to prove me wrong. But I'm making a claim that if we were, as OTs and PTs, offered our services, if we offered our services in the hospital after birth, we would see the maternal mortality rate and morbidity rate go down. We are the only professionals who do what we do, who assess vital signs paired with functional activity, who could spot someone who might be at risk of preeclampsia or readmitted back, because of a stroke or a brain bleed or a cardiac event because they overdid it
Mm-hmm.
without being given specific information that's specific to their home environment, to their social situation, to their support that they have at home. We're the only providers who do what we do. And if we were on the team, my claim is that we will see these numbers drop in terms of our morbidity rates and our mortality rates. The two are different, but right now we have a morbidity rate, meaning we have people that are suffering with short and long-term complications after birth throughout the first year and beyond.
Mm-hmm.
I think we can absolutely change that.
Yeah. And I just want to reiterate something that you just said, that as physical therapists and occupational therapists, we're going in and individualizing the needs of each person. So this is not at the physical therapist and occupational therapist go in and give a pamphlet and give some, basics of self-care, and then you're discharged. So I just want to make sure that people know what you're talking about here, that it's not just a cookie cutter. Here's a pamphlet. Here are some parameters to watch out for. Good luck. This is
Right. You are not
very
giving a handout.
individualized.
You are not giving a handout and walking away. You are taking that person's blood pressure, their heart rate, their oxygen, and you're measuring it over time, over the length of the activity that they're doing. You're taking that person's support system, you're modifying ways that they can do more with less energy, right? It's very specific to that individual, and giving them a handout is not the same as providing OT and PT. That's
Right.
not going to reduce the rates that I'm talking about. It needs to be individualized care.
Yeah, exactly. Yeah, I just wanted to make sure that everyone was very, very clear on that point. So as we start to wrap things up, what are the main takeaways for our listeners, whether they're physical therapists, occupational therapists, or none of the above? Maybe they're just moms. Maybe they are people who want to become moms or dads or, trying to start a family.
Yeah, so I have always believed this, even when I worked in oncology, is that change is going to be person driven, not really professional or provider driven, right? We see the issues, but we're out on the front line, and some of us are, yelling until we lose our voice. This has to be individual driven. This has to actually come from the birthing community that is affecting more, right? When you've had an experience, and say you want to still expand your family, but when you've had an experience of a birth that didn't go quite as planned, or you are that individual that tried to get up from the toilet within the first 24 hours and fell down, or you found that you weren't really listened to, or you didn't feel heard, but yet you're going to expand your family, or someone else who's going to go into the hospital after birth, here's what you say. You say, don't leave the hospital without an OT, without a PT consult. You ask for that consult. Chances are you'll get one of two responses. You'll maybe hear, well, we don't ever get that request. We don't have PTs, OTs, to provide those services. And you respond by saying, well, I'd like to try anyway. I'd like to actually have that person come to my room. I'd like you to make an exception for me. This has to be individual driven, and you have to keep asking in different ways for the same thing, but it has to come from you first. As an OTPT listening to this, You're going to come up against barriers and barriers and barriers. But once you start making connections with individuals who understand what it is you can do to help them, they will advocate for you. And it's easier right now as a patient to ask for services and receive them than it is for an OT and PT to demand that your services be offered to everyone. You're going to get more pushback, but start with the people that you're helping, convince them, and they will advocate for your services.
Yeah, it's those little individual drops that make a movement, right? So the more individual drops we can get, then we can become part of a movement. And once you're part of a movement, then you start to see more systemic changes.
Absolutely. And your insurance will more likely reimburse, and the provider will feel good about asking for your services if their patients want it.
Yeah.
We
Yeah.
didn't get pushback when we were actually asked for. You want people to ask for you. And so really my take home message is for the OTs and PTs listening is start talking about what you do more. Don't assume that everyone knows. Start talking about what you do. What you do is awesome, and tell everyone you can about it.
Yeah, great advice. And now, where can people find you if they have questions, they want some follow-up, they want you to come to their hospital and speak to their administrators or coach them on how to do so? Where can they find you?
Enhanced recovery after delivery. That one website will take you to the program that I teach, to OTs and PTs, the facility trainings that I do specific to that facility, whether it's in a rural area or a large metropolitan center, doesn't really matter. And also ask questions, gain information, get free checklists, just things that you can start to pile in your toolbox when you have those hard conversations, when you have that pushback. You'll find everything on there.
Perfect. One more time. What is the website?
EnhancedRecoveryAfterDelivery.com.
Perfect. And we will have the link to that at our podcast website at podcast.healthywealthysmart.com. And then question I ask everyone is, what advice would you give, let's say, to your 20-year-old self?
Mountain bike more and ski more. Girl, get out and have some fun. Take life too seriously. Totally. I would have been doing what I'm doing now a lot sooner.
Oh, awesome. Awesome. Great advice. And Rebeca, thank you so much for coming on and sharing all of your knowledge around the importance of hospital care after childbirth from occupational therapists and physical therapists. So I appreciate you. Thank you so much.
Thank you for having me, Karen.
And everyone, thanks so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.